Thank you. Now I recognize Mr. Arensmeyer for your 5 minutes of testimony. Thank you.
Good morning, Chairman Wahlberg, Ranking Member Blunt Rochester, members of the subcommittee. I'm the founder and CEO of Small Business Majority. Our mission is to empower America's 28 million entrepreneurs to build a thriving and inclusive economy. Working from 9 offices across the country, we work closely with more than our network of 55,000 small business owners and over 1,000 local business organizations. Over the past 6 years, the ACA has provided health care to more than 20 million individuals who otherwise couldn't access coverage, millions of whom work for small employers or are themselves business owners or self-employed individuals. Equally important, the small group market has seen rates stabilize under the ACA with an average cost increase of 5.2%, down from a rate of more than 10% prior to the ACA. It should come as no surprise that scientific polling we conducted last year found that 6 in 10 small business owners favor retaining and strengthening the ACA. That's why we're so concerned about the proposed changes in the Department of Labor's rules governing AHPs. In order for small businesses to receive affordable coverage, the small group market's risk pool must be robust and well-balanced. The proposed rule would allow associations to operate as a single large employer, thus creating separate risk pools for different types of small businesses, particularly when it comes to things like essential health benefits, age rating, actuarial value, adjusted community rating, the single risk pool requirement, and risk adjustment. While this might mean that some small businesses with younger, healthier employees can purchase cheaper plans, the remaining risk pool becomes unbalanced, causing rates to soar for everybody else. What's more, the proposed rule suggests that current protections against discriminatory marketing practices would not apply to AHPs, which would allow these plans to discourage enrollment from companies with employees that have expensive or complicated health issues. Under this proposed rule, AHPs would also offer fewer consumer safeguards. It's concerning that the proposed rule is ambiguous about whether it will block states' abilities to regulate AHPs. It's unacceptable to prevent state insurance commissioners from enforcing rules they deem to be in the best interest of their state's small businesses and consumers. Small business owners may turn to AHPs in search of lower cost options, but without protections in place to prevent fraud, they can find themselves the victims of scams, on the hook for costly medical expenses for issues they thought their plan covered. As Adam Rashan, the owner of a small independent insurance agency, says, the bottom line is AHPs are only good as long as you don't get sick. Importantly, AHPs are not a new idea. In fact, states have already experimented with these plans with disastrous results. An Urban Institute analysis of Oregon's regulations of AHPs prior to the ACA found that policies and lack of regulatory oversight increase the potential for adverse selection in the remaining small group market in the state. This issue, as well as the concerns outlined above regarding fraud and abuse, is why a coalition of 17 attorneys general recently submitted comments to the Labor Department opposing the proposed rule. As noted in their comments, the proposed rule undermines the intent and structure of the ACA and is also contrary to the Labor Department's long-standing interpretation of ERISA, which, among other things, requires that large groups have a, quote, common economic or representational interest, close quote, unrelated to the provision of benefits. Finally, much has been made of the proposed rule's inclusion of independent contractors or so-called working owners. This is a group that has dramatically benefited from the ACA's individual market, with as many as 1/3 of participants in California's exchange being sole proprietors. As such, enacting this rule would significantly weaken the individual markets. Rather than pursuing policies that undermine the ACA, we encourage lawmakers to advance legislation that would stabilize healthcare marketplaces and protect the robustness of coverage options for small business owners, employees, and independent business owners. Legislations like the bill that was recently introduced by the ranking members of the Energy and Commerce, Ways and Means, and Education and Workforce Committees would be an important step in lowering premiums and stabilizing markets. Thank you, and I look forward to answering your questions.
Thank you very much.
Mr. Arensmeyer, do AHPs reduce the overall cost of health insurance for everybody? Or just move it around so that different people pay different rates?
They do not decrease the overall cost. There are cost factors in the health insurance market are governed by many underlying issues, and as you're right, they just move it around.
Okay, so if you allow healthy people to form their own AHPs, what happens to everybody else?
Everybody else gets left in a group that's forced to raise prices, and most people are going to have their prices go up.
And what happens to stability if healthy people start forming their own associations?
Well, the stability of the market decreases. Congress decided we've got 3 basic groups, risk groups. You've got large group, small group, and individual, and each one of those needs to be as robust as possible. If you start to weaken any one of them, you weaken the whole system.
Now, if you form an AHP and people start in your program start getting sick, what can they do?
If they're in an AHP, if they start getting sick and the AHP starts to incur losses, the AHP could go away. And unlike a large group, which is there because everyone's got a common economic interest, in a big company, this is a group that's just set up for health insurance purposes only, and it could just disintegrate.
That means they can go back into the normal individual or small market pool.
If they would ultimately have to go back into it, yes, but you're talking about destabilizing a market in the process.
Now, what is the history of insolvency in AHPs?
There's been a tremendous history of insolvency. As I said, again, if you set up an entity for the sole purpose of providing health coverage, you don't have the foundation that you have in the large group market with a large company that's there for many reasons beyond health insurance. So once something starts to go wrong, there's absolutely no incentive for people to stay in the system.
So if the costs go up because a few people got sick, everybody will start bailing, is that right?
That's right.
Is it possible to design a benefit package that attracts healthy people rather than average people?
Absolutely. I mean, if you don't have the same rules regarding essential health benefits, you create different rules of the road. The reason that, and I should add, as I said in my testimony, the small group market, unlike some of what you've heard, has actually been relatively stable. In fact, between 3 and 199 employees, it's only gone up 1% in the last year. So that's how you have a stable market, is you have as much risk spread out as possible.
But if you had designed a program that you didn't have services for diabetes, didn't have chemotherapy, you didn't have AIDS medicine on your formulary, you would discourage people with those diseases from joining the pool, is that right?
That's correct.
And you would have a healthier pool as long as they stayed healthy, and everybody would be happy until somebody got sick.
That's correct.
Can you give some examples of what happened? You mentioned fraud. What happened? Can you mention what happens when people get defrauded in this situation?
Well, if they think they're signing up for comprehensive health benefits and then all of a sudden the AHP weakens, then they're out of luck.
What happens when the AHP goes insolvent?
The people don't have coverage anymore.
We've heard that nobody's going to really sell these skimpy plans because nobody would want to buy it. Doesn't a skimpy plan have the advantage of a very low price?
Absolutely. I mean, it becomes very attractive on the surface, and all of a sudden you find out it's not covering what you needed to cover.
And so the whole point of this is to lower the prices, and if you can get a low price, then people would be attracted to it until they get an illness that is not covered. Where they have done these, has the cost of the residual market, those that didn't get into an AHP, have you seen the costs go up for everybody else?
Absolutely. I mean, the cost increases in the small group market prior to the ACA, particularly when you had AHPs in the system, were much higher. I mean, the growth was higher. The rate of increase was higher.
Is there any problem with discriminating based on gender or designing a pool that has traditional male employees?
You can certainly design a pool, design a set of benefits to intentionally exclude or at least implicitly exclude certain people by not having maternity coverage, not having coverage for things that people who are older tend to get. Again, it's about having separate rules of the road than the small group market. The whole point of the small group market, as we just heard from Mr. Contalucci, it's actually, you get pretty common costs across the entire small group market because you have a common set of rules and a common risk pool.
Thank you, Mr. Chairman.
That later, but I would like to ask a question, starting with the fact that the Affordable Care Act, what was really powerful about it was that it afforded protections to older consumers, particularly as more people are living longer and staying longer in the workforce. And I worry that older business owners and older workers who could be left with fewer options or even more expensive coverage under this rule. AARP states in a comment letter that the rule could, quote, greatly increase the likelihood that working Americans, especially those aged 50 to 64, would face higher insurance premiums and the loss of access to critical health insurance coverage. Mr. Arensmeyer, are you concerned about the impact that the rule could have on older workers?
Absolutely. If you just look at the large group market now, the age banding between the most expensive for older workers and the least expensive is 5 to 1, whereas in the small group market, as you know, it's 3 to 1. So you're automatically talking about a situation where you would have relatively higher prices for older people, which would then create problems for small businesses with older workforces.
And another thing that concerns me about the rule is that it could discourage businesses with employees who have pre-existing conditions and health issues, or even people with disabilities, from enrolling in association health plans. For example, right now, small group plans must cover habilitative services, but under the rule, this requirement would not apply. In your position, would a plan without that coverage be attractive to, for example, a small business owner with a physical disability?
No, it wouldn't. And again, it gets back to the fact that you've got different rules of the road. We've heard a lot about the fact there'd still be certain prohibitions against overt discrimination, but that doesn't stop you from setting up a plan that has different benefits than the essential health benefits required in the small group market, and thereby discouraging people who might be higher health risks from joining that plan.
And my last question, earlier this week, the president announced his plan to combat the opioid crisis. And while I don't think we're going to debate the plan here, I will mention that I think it's really encouraging that the president and Congress are having this important conversation and actually having it in a bipartisan way. But I'm a little nervous about the rule and that impact on association health plans to avoid covering needed services for substance use disorder, entirely counterproductive to what we're saying that we're trying to do with stemming the opioid crisis. Would you comment on the importance of substance use disorder treatment and why maintaining coverage for essential health benefits is important?
Well, again, it gets back to the fact that you have different rules for different risk pools here. And there's no question you could, again, design plans that had less coverage for drug abuse treatment, and you'd then be skewing the market accordingly. So again, I'm going to stress that in the large group market where you have common economic interest in a company, there's an interest in covering everybody, with the best benefits as you can in that company. When you set up a plan or an organization or association that is purely for the purpose of providing health coverage, you don't have that, and you don't start off with a pool of people that you want to cover. You're saying, we're going to set up a particular plan, and then we're going to attract people to come into it. By definition, you're then skewing the risk pool that's in that market, making it not only different from the small group market, but different from a large group that's actually representing a company.
I'm just going to close out by saying the committee knows I've served as Deputy Secretary of Health and Social Services, Secretary of Labor, State Personnel Director. This issue of healthcare cost and quality has been one that has plagued us for many, many years. We need to all be on the same page and be doing it as one country, not a lot of different separate groups. Thank you, and I yield back.
I'm going to ask Mr. Arensmeyer this question. I represent New York's 13th Congressional District, which is home to many small businesses that are critical to the local economy, our neighborhoods, and workforce. If implemented, what exactly does this proposed rule mean for those small businesses and the health of their employees?
What it means is if they don't find the AHPs that they may have access to, if they don't have the kind of benefits they want, they are left in the core small group pool, but by pulling out the participants in that pool that are healthier and younger, their costs are likely to go up. Or if they chose to join an AHP, they're at risk. They don't have coverage for certain needs that they might have.
One last quick question, as I'm running out of time. How does this impact the ultimate risk factors that are considered for any pool of insurers?
Well, again, I mean, it comes down to you want as broad and robust a pool as possible. And there's operating by the same rules of the road. So when you start to play with that, and you start to pull certain people out of a pool, you start to create instability in the whole marketplace. I mean, we're all for competition, and we'd love it if there were more group plans participating in the small group market. So again, if they come in playing by the same rules, that'd be great. We all are concerned about costs. There's underlying costs in the system we need to deal with. It's a question of people in common pools that are joined by a common economic interest.
Thank you, Mr. Chairman.
Thank the gentleman. I recognize the
Mr. Arensmeyer, you referenced a letter signed by 17 state attorneys general, including Oregon's Attorney General Ellen Rosenblum from my home state. Could you explain why these attorneys general are so concerned about this rule and their ability to enforce state regulations on association health plans?
Well, based on the letter, I think they're concerned about a lot of the concerns that I've raised here about separate risk pools. They're concerned that, particularly in the interpretation of ERISA, that ERISA is based upon regulating plans that may not have the same rules as a small group market, but they are based on a common economic interest in the among the participants in that plan. So again, we've heard a lot about comparing large group plans with the AHPs. I mean, large companies like General Motors, IBM, Google, they have an interest in providing comprehensive coverage. We've heard that they most of them provide essential health benefits because they have an economic interest in doing that. There's no common economic interest in an association health plan that is set up purely to provide coverage and could go away tomorrow. That's not the case with a large group plan. Google's not going to get rid of its large group plan tomorrow because there's some issues with risk in it. So again, they're concerned that that ERISA, the way it was written and the way it's been interpreted, that this flies in the face of that. It's also concerned that it flies in the face of the intent of the Affordable Care Act.
Thank you. And I noticed in your testimony you mentioned an Urban Institute analysis of association health plans in Oregon prior to the ACA. That analysis found there was increasing potential for adverse selection in the state's remaining small group market. Could you just briefly summarize that study and comment on whether this proposed rule might lead to adverse selection?
Well, again, it gets back to what I'm saying. If you have something that's set up with separate set of rules, it's purely to provide health coverage, you don't have the built-in protections, just sort of market protections that you have with a normal large group plan. So there's a tendency to maximize, to try to keep the costs down by reducing benefits, and by at some point, then people start to get sick and they're not covered, and the whole system.
Thank you. I want to get one.
I want to ask a few questions of our witnesses. Mr. John Arensmeyer, you state in your testimony that because most small businesses currently purchase coverage in the small group market, it is important to protect the stability of this market. In your opinion, does the proposed rule contribute to stability, or does it undermine it?
We believe it undermines it, and again, as I said before, by removing certain participants in that market who are likely to be at a lower risk, thereby leaving higher risk folks in the small group market and increasing costs and increasing instability.
Under the proposed rule, associations tied together by the same industry or geographic area can form solely for the purpose of offering coverage. This means employers could form a new organization for the sole purpose of achieving savings by avoiding many of the Affordable Care Act's consumer protections. But what about small businesses and workers that want these protections? If they choose to stay in the traditional market, what could the rule mean for them?
Well, obviously, if they choose to stay in the existing market and you remove higher risk out of the small group, lower risk out of the small group market, you're going to end up with higher costs and more instability in what's left, and it's going to jeopardize the protections that they have. Again, it's really about, we welcome competition, and there's been a lot of talk about cost reduction. There's a lot of need to reduce healthcare costs in the whole system. But at the same time, if we're going to be talking about coverage and robust and stable markets, we have to have everybody playing by the same rules.
What role do you think states should play in regulating these health plans?
Well, traditionally, states have played a very significant role in regulating health coverage. And right now, it's unclear. And as Mr. Condalucci said, there's, states may believe they can still regulate these or recharacterize these groups as small group, but there would be a likely challenge under ERISA. So it again creates legal instability on top of the economic instability.
Plans. Now, we've heard some conversation here about the fact that, we really should give people the option for the catastrophic coverage. Mr. Lewis talked about that earlier. Again, Mr. Arensmeyer, I actually just had a hip surgery 8 weeks ago. And, after one night in the hospital, it was, get out of here. And because as we know, healthcare has shifted outside of hospitals now. I mean, the notion that the old days of catastrophic coverage, actually, that was where the majority of healthcare was delivered, back in the 60s and the 70s, in the heyday of catastrophic coverage. The essential health benefits, which was part of the Affordable Care Act, was grounded in the Institute of Medicine going out and analyzing, what is healthcare? Where is it delivered? And that's really what was sort of the structure in terms of making sure that people are going to get the necessary care that they need. And catastrophic plans, which just take care of hospitalization, that doesn't work in the 21st century. And I was wondering if you could comment on that.
Well, absolutely. And I want to echo what the ranking member said, that the way we're going to, first of all, the ACA needs some fixes. I mean, we're the first to argue that. But we need to do this on a common ground, working together, and with a common risk pool, with common rules of the road. And if you start to sort of balkanize or break off different pieces of the market, it makes it much harder. Essential health benefits not only were put in place to cover what was generally perceived among professionals to be stuff that should be covered, it also was a common set of rules. And again, to state again, Mr. Condalucci said the small group market, as a result, doesn't have a lot of price differences in it because of that. So we would absolutely, we want to see more competition. We want to see fixes made to the Affordable Care Act, but we want that done with a common set of rules.
Thank you.
So again, I thank you for our committee's efforts. I thank the panel for being here today. But with no further agenda before the subcommittee today, it stands adjourned.